there's a couple of charts on here.
Okay.
That may make it easy.
Okay, this is Dr. Jeff Overdyke on the 3Ds, Delirium, Depression, and Dementia.
Okay. And so our goal with the 3Ds is gonna, and tell me if y'all can't hear me. The last time I did this, I don't think I talked loud enough, so feel free to interrupt me. But the 3Ds, delirium, depression, and dementia, can cause a change in a person's personality and behavior. And a personality should never change. Once it sets in when we're in our 20s, that should last our whole life. So if you ever see a personality change come on to somebody and they haven't had psychodynamic therapy or anything like that, then that should be a warning sign. Grumpy old man is not a real thing. Okay. The knowledge of these 3Ds, delirium, depression, and dementia, can also be used as a guide when we're diagnosing dementia. Also understanding and handling those changes in these personality traits. So delirium and depression can both be mistaken for dementia, and ruling them out is necessary to make the diagnosis with dementia. We don't have any labs or images that say you have dementia, so it's a diagnosis of rule out. Also, the knowledge of the 3Ds will help with diagnosing dementia, but also help control behavior throughout the dementia illness. So all of these cause behavior changes, and being able to recognize which one is doing it is good, especially if you're at the bedside and you know this person better than the nurses and the doctors do. So this is Peter Ravens. He's the guru of dementia up at Johns Hopkins, and he says, among caregivers of patients with dementia, behavioral problems are the most common cause for institutionalization or nursing home placement, rather than the cognitive or memory problems. Those are pretty easy to handle. It's when they start getting angry and swiping and things, that's when it's a lot harder to give caregiving. And so the causes, and this is something to memorize, the causes of any behavioral changes, we need to go in order of these 4 things. The first one is it the environment? It's kind of a 4th D, domestic. Do they have a new roommate? Do they have a new nurse at the nursing home? Is there something going on that's been a change in their environment? Is there a timing problem? So that's paying attention to something new. Any change is hard at any age. Is it, the next one to rule out would be delirium, because this is a medical or a neurological problem. And we'll talk about all of these in deeper detail. Is it a psychiatric problem like depression? Or is this due to the dementia itself? As you progress through the dementia, behavior becomes an issue. Usually, and we'll talk about that, but it's usually in that 7-year, 6-year moderate stage. But thinking about dementia, it is going through childhood backwards. And so you get the terrible 2s again, and that's kind of how to think about it. Question?
I didn't get the last one.
Okay.
Due to dementia. Okay.
Oh, yeah.
So this is 4Ds, but medically we say 3Ds. Okay. So what are those environmental causes? What could that be? Like I said, is it a particular staff member or a new caretaker? You order a caretaker by phone, they come in and there's just a clash. Personalities don't always get along together. The people in charge of that should not take it personally. They should know this. They should say, okay, well, we'll send you somebody more laid back or somebody more stimulating or something like that. They shouldn't take offense to that. So feel free to say, that one didn't work, send me a new one. Did they, in a nursing home, did they get a new roommate? Is it too loud? Is it not loud enough? Are they in pain? If y'all have pets and they have a pain problem and you touch it, what do?
Yeah.
They bite you, yes. So we don't always verbalize things. Sometimes we do actions instead of words. Is there enough light? Is it too dark in their, that they don't have that wake-sleep cycle thing going? Are they sleeping at night? That's a big one for you and for them, for their behaviors. And so we want to make sure they sleep at night. So this takes us to the first D, delirium. So delirium is a rapid change in consciousness. And consciousness is how awake you are. A rapid change in consciousness due to a medical or neurological problem. It can cause confusion, it can cause disorientation, and it can make people see and hear and believe things that are not true, psychosis. In the hospital, it can be called other things, encephalopathy, organic syndrome, ICU psychosis. There's a list of 100 of these things, but we'll call it delirium to go with the D's, I guess. And so some of the different symptoms of it. Consciousness is affected, and what that means, if y'all have ever seen it before, is they'll be talking and fall asleep in mid-sentence, or you're interviewing them and you can't keep them awake. It comes on rapidly. They wake up with it within an hour or within a day. This is a fast-acting thing. It comes and goes. They may be good in the morning and bad in the afternoon and then good at night again. So it kind of waxes and wanes. Their mood can change. Their cognition can change. So when we give them one of those little bedside memory exams, they get a 2. A dementia person would get a 20. 30 is the maximum, but they can't answer anything. And they may have hallucinations, delusion, irritability, agitation, or they may not move at all. They may go catatonic with this, where you pick their arm up and it'll stay there, and they just don't move or talk or blink or anything like that. So it is a medical problem, and it should be considered an emergency. If something like this comes on very quickly, you need to get it checked out. As we age, we are also like cars, babies and cars. We just don't have as much margin of error. When you're 20 and in college, you can go 2 nights without sleeping because you're studying, and you're fine. If you go 2 nights without sleeping when you're 80, you're going to be dreaming while you're awake or acting strangely, something weird. And this takes the place of a fever for the elderly. And so taking their temperature does not give a whole lot of information. Their temperature runs low, so if they're at a 98.6, that's pretty much a fever. If they're at 102, that's an emergency. But if they start acting like this, that means there's an infection, there's something going on. It is reversible. So this is something that we can reverse. And here's an acronym for it, a very dark one. I watch death. And so they could probably come up with something a little cleaner. But I would be infections, a pneumonia, a urinary tract infection. Urinary tract infections are the classic answer if you're taking a test on this. Encephalitis would be a brain infection. Are they withdrawing from alcohol? You admit them to the hospital, on the second day they start acting strange. We didn't know that they drank every day. Are they coming off of a medicine like a Valium or an Ativan or something like that? Those have withdrawals. Is it an acute medical problem? Did they come in after taking alcohol or one of these pills or any kind of drug? That would go with toxins as well. Opiates, steroids, anticholinergics. I had to take a lot of steroids and I became manic. I was scaring my children. The C would be CNS, that's central nervous system. That's our brain and all of our nerves. Did they have a stroke? Do they have a tumor? Are they having seizures, a bleed, infection? Hypoxia, that's low oxygen. That would be from a heart problem or a lung problem, pneumonia or something. Deficiencies, This would be a lab test. Are they low on thiamine? A lot of times if you, back in the old days, it was you didn't eat certain foods, but now it's if you drink too much, you're not absorbing thiamine, and that can cause confusion. B12 deficiency. E is endocrine. That would be thyroid usually, or sugar problems. A is acute vascular. T is trauma. They fell, they hit their head. And H is something more rare, heavy metals. That's not as popular today as it was back in the early 1900s, where we had a lot of lead and things like that and everything.
A timeout. I'm making copies right now of all these PowerPoint slides for y'all to take home. So, okay.
Oh, good.
I'm still a writer. Like I'll
Me
take
too.
it.
Yeah,
It's how I
that's
learn.
fine.
Just
Yeah,
yes,
that's fine. Yeah.
I can't write that fast.
Yeah.
Medications are a big
Yeah,
cause, and these, if you're taking them every day, this can be a long-term delirium. And this is just a very, very, very small piece of what's called the Beers list, which is 50 pages long of medicines we should not give to people over the age of 65. The most popular ones, and I'll give an acronym for this one in a second. Anticholinergic, that would be your Benadryls, Vistarils, things like that. They're over the counter, but do not give them to anybody over. Nobody should take those unless you're having an allergic reaction.
I took some this morning.
It's not a good sleeping medicine. Cardiovascular medicines can also cause some deliriums. Older medicines like tricyclic antidepressants,
What are
barbiturates.
some names of tricyclic antidepressants? What are some? Give me an example of those, please.
Well, we don't really prescribe them
Okay.
anymore because they have so many bad
Okay.
side effects and you can overdose on them. And if you didn't ask me,
That's okay.
I
That's
could come
fine.
up with a few of them, but they were
They're not commonly prescribed.
no.
Okay.
They're not like oxycodone or something like that.
Oxycodone, yes, that would be an opiate, and so that would go at the bottom, the pain medicines.
Okay, never mind.
And then
Ahead of me.
insulin, if you're taking too much insulin and your sugar goes too low, that can go. So this is just a brief idea that medicines can do this. So anticholinergics are the most famous, and this is little things we do to remember it. They can go blind as a bat. Mydriasis is a pupil dilation. Dry as a bone. Your mouth dries out, skin, eyes, everything dries out. Mad as a hatter. You get agitated, you can see things, you get delusional. Red as a beet, your skin turns very red. Hot as a hare, feel very hot all the time. And then this one is a very bad one to have. Full as a flask. That means you cannot empty your bladder. And I have seen it in the ERs where they come in, they can't really describe what's going on, they get a catheter and they are better instantly. That is a very, very painful and very frustrating thing to have, but these anticholinergics can do that. One to add in there, and this is a different kind of symptom, but this is the restlessness, or the pros call it akathisia. And this is an uncontrollable need to move or unease. And we probably all had this at some point. If I'm sitting in a classroom, my legs get jumpy, or on an airplane especially, I have to get up and walk around. Medications can cause this as well. Also, you remember commercials for restless leg syndrome, that would be describing this. But medication causes, antipsychotics are probably the most famous for causing this. And we're going to talk about these because we use these as a treatment for some of the 3Ds. Antidepressants can sometimes do it, but not like the antipsychotics do. Calcium channel blockers, which some people take for their heart. There can be medical causes. People with Parkinson's can have this restlessness. Dementia can cause it. Somebody with a brain injury or brain swelling can get this. And then we have, if they're restless, sometimes these mistakes can be made. A doctor will think in the hospital will think that they're acting out, and so they'll give them an antipsychotic. And what's the antipsychotic going to do? It's going to worsen it. And to tie down somebody to a bed with this is torture. And so if you're at the bedside and you see that they can't sit still, that's something to tell their nurse, because they would give them one of these medicines. If their blood pressure is high enough, they can give them propranolol. That's a beta blocker. Or else we can give them the little yellow pill, Valium or clonazepam, or the seizure medicine, gabapentin, or Neurontin is the other name for that. That can sometimes calm them down. But that's a very uncomfortable way to be. And you may see this a lot in the nursing homes where people are just pacing constantly. If you're not able to walk and you get this, they're going to try to walk and they're going to fall. And that's a hard thing, but this is something to pay attention to so we don't make it worse by treating the wrong thing. So our workup for delirium, being a medical illness, we would get labs for all the iWatch Death stuff. We would want to get a urinalysis, and I always insisted on a urine culture as well. Sometimes
That restlessness, could that be attributed to ADHD or vice versa?
It can be, but it's a different way. That's just more of a, I feel like you have to be doing something, but you don't have the physical urge to move your legs and walk around. It's an urge where if you're not walking, you're shuffling and bouncing your legs, and it's usually legs. I got disagreed with most of the time getting a urine culture, but sometimes the urinalysis just doesn't show everything. You want to get a drug and an alcohol test to rule that part out. A complete blood count would show you if there is an infection or a reaction to something. And then an oxygen level, some thyroid, B12, folate levels. And then you want to check for pneumonia with the chest x-ray, check for a brain problem with MRI. That could show swelling like with normal pressure, NPH, normal pressure hydrocephalus, or maybe they had a small stroke or something like that. And so this would rule most of the things out. Do we always find the cause? No. But we want to treat it as a medical problem until it goes away. Because sometimes the labs do show something a week later. It might just be too early when we're looking. So what we want to do is we want to get them sleeping at night and awake during the day. Oftentimes it's too dark during the day and they sleep, or it's too light at night and they're not sleeping, and so we want to get that cycle back going again. Some of the statistics on delirium: if they're in the hospital and they're over 65, 30 to 40% of those people may get delirium.
Close to that age.
In nursing homes, 60% of people get delirium. We're going to talk about the post-operative delirium, but that can be up to 50%. And so when we're testing for dementia, we have to rule this out because 15% of those people could have a reversible delirium. Mm-hmm. And we don't want to just label them with dementia before ruling that out. Because this is a sign of like a fever, or they can have delusions. This is a fatal illness and it may last for 6 to 8 years. Frontotemporal dementia, it comes on earlier than the other dementias, 45 to 65. You may notice a change in speech. They may be speaking nonsense, or they may be stuttering on words, a change in behavior, or both. It may have more speech than behavior, more behavior than speech, or it can come together. And it's called frontotemporal dementia because that's the part of the brain that's being affected. I don't know if y'all ever remember the railroad worker that had the accident. His, I can think of the name in a minute. Can't tell I have some speech problems. But he was a good guy, didn't drink, worked hard. Somebody put too much powder in a hole, he was tamping it down, and the rod shot up under his eye through his brain. He didn't die. They took him to the hospital, removed the rod. I guess he's okay to go back to work. He goes back to work and he's sleeping with all of the prostitutes, drinking, getting in fights. His personality changed. That's because his frontal lobe was damaged. Also, the other frontal lobe is why they used to give lobotomies to people back in the day, and that would be to give the other result, which would be just to sit there and stare with no behavior at all. One of the Kennedys got it, I think. John F. Kennedy's sister, I think, had a lobotomy. So there's less memory loss with this dementia. It may last 8 years. People mostly die from pneumonia when they have this. And that leads us to the main one, the most common one, Alzheimer's. And so this is the curve of Alzheimer's. The first 5 or 6 years, they may have a few functional problems, some memory problems, but they're still them. They do okay. And then there's a steep curve around the 6 or 7 year mark, and that's where we get the behaviors. That's the moderate to severe stage. They'll stop talking around here, and so they can be full of language that doesn't feel good, and behaviors too. When we're treating Alzheimer's, we want to start as early as we can because it can slow it down and keep them on that top plateau as long as possible. And sometimes it can help with the behaviors, and we'll talk about the treatment. And so what are the functional changes? At the beginning, you get the instrumental functional changes. That would be balancing their checkbook, doing things that have more than 3 steps, tying a tie, preparing a meal, using a phone, especially now. Going to an unknown place that they're not used to going to. As it progresses, they stop knowing their basic functions. That's bathing, dressing, walking, feeding, toileting, transferring from bed to chair. They are going to fall. They are going to lose their ability to walk. You cannot blame the medicine. You cannot blame that. That's going to happen. They're going backwards through childhood, and they almost forget things in the reverse order that they learned them. Everything except for speech, it seems. They also have some non-cognitive changes, some non-memory changes. Their personality can change. They can become apathetic, where they just don't seem to care about anything. Depression can happen in up to 25%. That can happen before the diagnosis. That can happen late in it. It usually happens on that curve part. They can become anxious. We'll talk in depth about delusions. That's 30 to 50% of them. They can have hallucinations. Those are usually visual. They can see things. They can get agitated, and then their sleep can come off its normal rhythm. And so we want to start the medicines early. We want to slow this down. We don't have a medicine that can get rid of it. We just have a medicine that can keep them on that top plateau as long as possible. That medicine is not a miracle. You may not notice much, but it can help slow things down. It can also help with some of the behaviors, the apathy, the attentiveness, the conversational part. They usually work for 1 or 2 years. They usually take a few months before we start seeing some of the improvement. These are a list of them. The cholinesterase inhibitors, that would be your Aricept, your Exelon, your Rimonil, the generics are donepezil, rivastigmine, galantamine. And then the add-ons would be the NMDA inhibitors, that's your Namenda or memantine. And so the way I used to prescribe these, I'll get to that in the next slide, but they can have behavioral changes with their dementia. And so you want to rule out those first 3. Is it the environment? Did they get a new roommate or a new nurse? Do they have an infection? Are they depressed? Once you rule those out, then you want to be as specific as possible. You don't want to tell your doctor they're agitated. That does not have any information associated with it. What we want to do is we want to try to pinpoint what's happening so we don't just do a overall shotgun approach and put them to sleep, make them sleep all day. So are they psychotic? Are they seeing things? Do they think things that aren't true? Are they aggressive? Are they hitting people? Are they just being loud and yelling, cussing people out? Are they wandering or pacing, that kind of akathisia, the restlessness thing? Are they repetitive? Are they having sexual X-rated kind of things? Are they smearing their feces on things like a baby might do? And so we want to know specific what's going on, what time of day is it going on, and that would help change it and also help keep the quality as good as we can. The way that before we get to the delusional part, the way I would prescribe the memory medicines, I would start, say, an Aricept at half a dose after their memory starts to show some problems. I'd see how long that helps. If they start having memory problems again, that would be in the 6-month range. Then I would give them the full dose. Give that some time. If that starts fading away, then I would add the NMDA, the memantine medicine. And so that's kind of the 3 steps I did. Different doctors do it different ways. So what are some of the psychotic behaviors that can come with it? The delusions are the most prevalent and also the most affect the behavior the most. So as mentioned, 30 to 50% will get delusional behaviors. They can think they're being stolen from, they can think they're being cheated on, people are persecuting them. It's very closely associated with aggressive behavior. They're in danger, they're going to defend themselves. And so 80% of people with frequent aggression tend to have delusions for more than a month. And so we want to be clear, what kind of delusions are they having? Sometimes they might have some misidentification delusions. That would be 30% of these kinds of delusions. One of those is Capgras syndrome. That's where your caregiver has been replaced by an imposter. You look like my husband, except his mole was on this side and now it's on this side. Their home is not their real home. They're in some kind of fake set kind of thing. They watch TV and they think that that's real, that's in their house or something like that. And so these can just be misidentifying things. They can also have hallucinations, and you would think that this would cause a lot of behaviors, but it doesn't. 10 to 15% of dementia patients can start seeing things. Remember, Lewy body, it happens early. Dementia, it happens later. Are these scary hallucinations? If they're not scary, we don't need to treat them with a heavy-duty medicine. If they are scary, we should treat that. And so, like I said, they're less predictive, and that's strange because you can be interviewing somebody and they're staring out of the window. You ask them, what are you looking at? And I've heard things that are very scary. There's a bunch of babies outside with no eyes and their mouths sewn shut. And you're like, well, why can you just sit there and look at that? I'd be panicking. But they see these things and it's just so dark and it's scary. But they just stare. Mm-hmm.
Been there, done that.
Yes, it's. I don't know how they come up with some of those. It's very scary stuff sometimes. Or sometimes it's little elves running around, cute, a dog laying by the fireplace or something like that. Not very scary. So what do we do to treat these things? And this is where you need to be very specific. Is it psychotic or is it not psychotic? The way we want to do the medicines is we want to just do a daily dose of something. That preventing it is easier than fixing it. And so if they're doing this on a daily basis, we can give them a medicine to try to keep that from happening. If we wait for it to happen, the as-needed medicines, like you see in hospitals, are shots and they go to sleep. And we don't want to do that frequently. So we want to try to prevent them if they're happening a lot. And we want to be specific, like I was talking about. As the behavior goes, after it gets off that curve and goes into that flat line, these behaviors will go away and they just become spectators. So this is not something that we have to do for the whole time. And so these medicines can be weaned after they get to that severe stage. If they're psychotic, we want to use atypical antipsychotics to minimize the side effects of the older antipsychotics like Haldol. These do have side effects. They cause sedation. They can make them have Parkinson's symptoms, especially Lewy body dementia. They can make this restlessness like we were talking about before. And they do have an FDA warning, a black box warning of sudden death. And the commercials make that very frightening. So we try not to use them because of that. But if we look at it in a scientific way, you have that sudden death risk without medicine, 0.7% of the time. If you add one of these medicines, it doubles it to 1.2% of the time. And so that's not a huge leap, but they sure do make it sound like that. But if they're fighting off hallucinations and hitting people they think are stealing from them, the risks outweighs the benefit outweighs that risk. We want to prescribe things at night if possible, since they're sedating. But if it's a time of day that it always happens, like if it's the sundowner syndrome, then we could maybe time it to be 4:30 to prevent that from happening or something. And the sundowners thing happens to babies, if y'all remember your kids doing the same thing, that they'll be cute all day. You get home from work and they're not cute anymore.
I call that the arsenic hour.
Yes, and so I promised they were cute all day, and I don't believe you. So morning or early afternoon may be needed if it's happening all day or something like that. So if they're psychotic, we want to target that behavior, or if they're not psychotic. And so buspirone can do, if they're loading and unloading a suitcase, that can kind of help with that, or repetition behaviors. Trazodone can be helpful for sleep. Valproic acid, which is Depakote, is a seizure medicine that can help with some of the anger. Gabapentin or a beta blocker or one of those nerve pills can be helpful for that restlessness. If they're not effective, then hospitalization may be needed for safety until we can get that behavior to go away, because we don't want them falling, we don't want them injuring anybody, we don't want them getting in the car and moving down the interstate at 80 miles an hour to get away from whatever's chasing them. So we want to keep them safe. And so this is the chart that separates the 3 Ds. The onset, did it come on within hours? That would be a clue for delirium. Depression, weeks or months. Dementia, months or years. Who complained about it? Delirium, that would vary. It's usually the caregiver. Depression, that would be the patient. And then dementia, that's usually the family. Depression has insight. Dementia usually does not. Their consciousness, that's the falling asleep at random times. That's delirium. The other two are clear with that. So if they're falling asleep mid-sentence, or if it's coming and going, where part of the day they're okay, and then the other parts they're not, that would tip us to delirium. And then reversibility. We can treat delirium. That's the medical problem. We can treat depression. We cannot treat dementia. That is a fatal illness. And so this can kind of help tease these things apart. I can answer questions, or I have a few situations, and y'all can try to guess. Looks like we have 5 minutes left. Do y'all have any questions first? Or would y'all like a situation, a trivia game, and we can try to do that in the last
Are there prizes?
Mhm.
Are there prizes?
Yes.
Okay.
Giant pat on the back. You're safe. You can sleep at night. All right, so say there's an 81-year-old female who's been living independently, and she is now in physical therapy rehab after a knee replacement. You go to visit her, and she looks terrified. People are being taken to the basement and being tortured. I'm next. Get me out of here. Would that be dementia, depression, or delirium?
Delirium.
Good, from the W's after surgery.
But I have been in physical therapy and felt that before.
That they're going to the basement.
They're torturing you.
Yeah. Well, it's a one-story place, there is no basement. And yeah, that can be a nice way to be mean. You have to get out of bed and walk, otherwise you won't walk. All right, winner. Another one, a 79-year-old male with a 4-year history of Alzheimer's. Seems different in recent weeks. He does not want to visit with you. He's not eating. He snaps at you when you ask him if he's okay. He spends most of the time in bed staring at the ceiling, and he's not shaving or grooming himself. What would y'all call that?
Depression.
Good. With dementia, yeah,
Right.
they have dementia too. Okay, another one. You go to visit your 88-year-old mother who has depression and dementia, Alzheimer's. That was diagnosed 6 years ago. She's living at a nursing home. She stays in her room, packing her things all the time, does not go to the common area like she used to. You see a newly admitted person sitting at the table where she usually sits. She just won't go to the common area anymore. What would be to blame in that situation?
Dementia.
It is the dementia, but it's also a change in her environment with this
okay.
new person coming in and sitting at her
Gotcha.
table and they don't
I
click.
thought they were there because she wouldn't go there.
And then after we roll all that stuff out, if it's still there, then it may be the dementia. Okay. All right, well that's all I got.
Good job.